I'm going to show you how three-dimensional ultrasound is so important in the treatment, in the diagnosis and treatment of infertility patients. I have no disclosures, and our learning objectives are to appreciate the advantages of 3D ultrasound in reproductive medicine, showing uterine morphology and pathology, uterine cavity evaluation, tubal morphology and patency, and ovarian reserve assessment and follicular monitoring. We want to give you a basic knowledge of the automation technologies that can enhance efficiency, and you will become familiar with the concept of the one-visit infertility workup. As an introduction, I want to show you our operating rooms. As you can see, we always have 3D ultrasound in the room, both for IVF procedures and for hysteroscopy. And here you can see our setup for hysteroscopy, and my colleague Manuela Costa will explain in detail later today the new concept of an operating room integrating hysteroscopy and 3D ultrasound. And I think it's it's just an opportunity for us, because we need the ultrasound in the operating room for egg retrievals and transfers, and so we just started to use it for hysteroscopy, and we ended up using it all the time. The other thing I want to mention is how in infertility treatment the percentage of PGT, pre-implantation genetic testing, has increased over the years. As you can see, we did less than 5% until 2013, and now almost 50% of our cases are with PGT, in part because of the increased age of patients that come to us. And our pregnancy rates, as you can see, our is a medium-sized program with about 600 cycles a year, and our pregnancy rates go from 60% per transfer in egg donation and young IVF patients to 15% in women over 43. But as you can see, in this age range, pregnancy rates go down to ongoing pregnancy rates go down to 6%, where 26% is what we get with PGT. And as you can see, pre-implantation genetic diagnosis is mostly important over 37 years old. As you can see here, we can increase pregnancy rates in this age range. Over the years, our implantation rate has improved while we have reduced the number of embryos transferred, and basically we're doing single embryo transfer in everybody, because older patients get PGT, and in egg donation, of course, we transfer only one embryo. And we believe that our success depends not only on the technological improvements implemented in the IVF laboratory, but also on how we take care of patients, how we prepare their uterus, and especially to what we do with 3D ultrasound. So the way we use 3D ultrasound, and you will see this along the course. We have gone from clunky machines that we used just a few years ago to very agile ones, like the Swift that you will see in the course, in the hands-on part. And so we also had tremendous improvements in software, from multiplanar reconstruction to vocal, to sono-AVC, and you can see here we can do sono-AVC with the antral tool that was introduced just a few years ago, but now we've improved. Now we have artificial intelligence incorporated in the machines, and with the sono-AVC follicle 2.0 software, we can have a much better result, as Dr. Rouleau will show you in his talk. And here you see a uterine trace. From a standard sagittal view, the endometrium is traced on the touch screen, and the system acquires the volume automatically, displaying the coronal plane. Uterine trace is a new feature that enables easy visualization of the coronal plane, and as you can see, you can use VCI to enhance the details, and again, you'll have an opportunity to see all this during the hands-on. Regarding the one-visit infertility workup, this improved technological ability has allowed us to accomplish what used to take multiple visits in a single visit. With advances in technology, incorporating 3D ultrasound into a reproductive medicine practice has become easier and more cost-effective. And I will show you how we do that, and all of my colleagues will show this during the course. So we do a telemedicine. When the patient comes, we schedule them for the correct day of the cycle, where we can do both antral follicle count and sonohysterogram, exome foam, whatever is needed. So you see here a normal uterus, and this is a 3D multiplanar reconstruction with VCI, and that's the rendered image. And we can do two tomographic TUI with VCI, and that gives us an image that's very similar to magnetic resonance or CT scan. And you will see how important this is for uterine malformations and other pathology. So the advantage of 3D ultrasound is that it's pretty quick, and with the patient there, we just acquire a volume of the ovaries, of the uterus, and then we can, when the patient has left, we can manipulate those images and take measurements and do whatever is needed. Here, we acquire a volume of a uterus during the sonohysterogram, and this is not the right talk, but it's okay. It's virtual hysteroscopy is what we do, what we can do with the ultrasound. This is a sonohysterogram, and we can manipulate the image to show the polyps and to show the cavity. When we go moving on to uterine malformations, this is you've seen now how from a single scan we can process it and get multiple presentations to select the information of interest. This is a multiplanar reconstruction of a unicornuate uterus and the corresponding TUI and a rendered image. This is an incomplete septum, and you can see nicely how we have two cervixes here, and before ultrasound, the classical teaching was to perform a laparoscopy to visualize the uterine fundus when performing a septum resection. Now we don't need laparoscopy, and we do the same procedure under ultrasound control. Okay, gracias. So here we have other images with multiplanar reconstruction and the OmniView. And this is another case with double cervix. Okay, you see here a uterus with a 4 centimeter isthmic fibroid. The coronal plane allows accurate localization mapping of the fibroid, and in this case, as 3D ultrasound gives information comparable to magnetic resonance, being very accessible and cost effective. And again, the TUI here. This is a case of a submucous fibroid here, very small, with the corresponding TUI, and you have it here in the rendered image with HD Live. And here is what we can do after sonohysterogram to do what we call virtual hysteroscopy. We just manipulate the image, and just as you can see here, it's almost as doing a diagnostic hysteroscopy. You can see the details, and in the end, this fibroid will come up. So we don't need diagnostic hysteroscopy. It's good enough to do a sonohysterogram and then to go directly to the operating room for hysteroscopy. Here are just some images of the fibroid mapping tool that we have in the most modern machines. And although this software needs some refinement, is really very nice. And here is an image of a uterine polyp. And this is a complicated case with submucous fibroids and polyps, and we can nicely see these anomalies with 3D ultrasound. And if we do a TUI, tomographic ultrasound imaging with thick slices, we can see all the pathology in this same image. We go on to assessment of fallopian tubes, and here is a sonohysterogram of a tortuous fallopian tube with thickened wall while evaluating tubal patency. So it has tubal patency, the fluid has passed, and when we pass with the fluid, the details of the tube are seen very nicely. And you will see later how, in the specific talk about tubal patency, how we can see nicely the anatomy of the tubes with 3D ultrasound. This is the same that we do with the uterine cavity, we can do with the tube, doing a virtual salpingoscopy to do, this is a hydrosalpinx case, another one. And this is the inversion mode, where you can nicely see the tube. Okay, we move on to assessment of ovarian reserve that we will cover by Dr. Rouleau. And here the video is not. Well, video is not working. So now we use a better software that with Sono ABC 2.0 shows the acquisition of follicles. And so this is how we acquire an ovarian volume and do a Sono ABC. And this is the old software. It took a little bit more time, and needed a little bit more post-processing. Now the follicles should appear. And here is a case where the report appears, and Dr. Rodriguez will explain this in her talk. And this is the new baby, that's the SonoVC 2.0. And you see how no matter what image quality is, in a few seconds, we scan the ovary and we get the follicles. So really monitoring takes very little time compared to 2D ultrasound. So this is the study that we published in 2010 about SonoVC, showing that it was faster, more precise, and allowed decision based on follicular volume. And at that time, so more than 15 years ago, we postulated the hypothesis that we could use volume to create new trigger criteria. And we then came up with this other paper that was Dr. Rodriguez's thesis, and we based this study on follicular trigger in this study was based on follicular volume according to our standard protocol, that is having at least 2 follicles with a volume greater than 2 cc's, with 70% of the follicles having a volume greater than 0.7. And Dr. Rodriguez in her talk will show you how integrating this data with AI, we can get newer trigger criteria. So to predict the oocyte yield, is follicular volume superior to diameters? Yes, we think that's the case. And so we have shown that by individualized follicular puncture, that a mature oocyte is associated with follicles greater than 0.56 cubic centimeters. Now, we go to embryo transfer. We use 3D ultrasound after the transfer to identify the embryo flush. And we started, as we will show in a talk tomorrow, that we started to use 4D guidance for embryo transfer. So we confirm pregnancy with 3D ultrasound, and that's nice. This is a picture of several years ago that Dr. Vicario did, where you can see how you see the decidua, the extraembryonic mesoderm area, the trophoblast, the embryo, the yolk sac, the chorion, the amnion, all the layers with the silhouette mode can be detailed and seen. And when we go to pregnancy confirmation, 3D ultrasound is extremely important for extrauterine pregnancies, and especially when we have, cornual pregnancies and pregnancies in the isthmic portion of the tube. So I hope I showed you that with advance in technology, incorporating 3D ultrasound into reproductive medicine practice has become easier and more cost-effective, and we convert basically a single scan into a tomogram which then lets us see all the details. So with this, I think, thank you again for your attention, and we can move on to all the other talks.